Today, our focus turns to developing a holistic approach to the subfertile man, and this webinar will give an overview of how the male partner can be assessed when presenting with possible subfertility. And we'll specifically look at the clinician's perspective and the role of the laboratory. We're incredibly lucky to have two presentations from Sarah Martins de Silva and Denny Saccas. I'll introduce Denny more fully immediately before his presentation, but we'll start with the presentation from Sarah Martins de Silva. Sarah is a senior lecturer in reproductive medicine. She runs a translational research program focused around male infertility, sperm biology, and drug discovery. And she was recognized for that research in 2019 and named as one of the most inspiring and influential women from around the world by BBC 100 Women. Sarah studied medicine at the University of Edinburgh and qualified with a MBCHB in 1995. She's now an honorary consultant gynaecologist and clinical lead for NHS Tayside Infertility Services and the person responsible for Nine Wells ACU. Her clinical activities include diagnostic ultrasound, infertility clinics, and assisted conception, and she runs specialized male infertility clinics as well as sperm studies research clinic for couples affected by low or no fertilization following IVF ICSI. So now it's over to you, Sarah.
Hello, my name is Sarah Martins de Silva. I'm a consultant gynaecologist, a fertility specialist, and I run a translational research program focused around sperm biology and male infertility. I'm grateful to Cooper Surgical for the opportunity to speak, and today's topic is developing a holistic approach to the subfertile man. Conflict of interests are declared on this slide. Although I am a paid speaker for this presentation, the views expressed are my own. It is estimated that 1 in 7 or 15% of men are infertile, accounting for at least 30 million men worldwide, although higher rates of male infertility are seen in Africa and Central and Eastern Europe. 1% of men are azoospermic, but the majority produce sperm, just fewer in number or with poor motility. Sperm function is not well understood, and the reality is that there is, apart from very rare exceptions, no treatment or cure for male infertility other than IVF ICSI, which is an effective solution, but treats the partner and not the problem. So the issue is that we have limited understanding of how a sperm swims, finds, and fertilizes an egg. And if we don't understand how a sperm works, then we can't possibly understand when they don't, or how to correct the problem. And there are very real difficulties and challenges in sperm research because they are very small, and they move, and they have virtually no cytoplasm and mainly rely on post-translational modification and even cell signalling pathways that are often unique to sperm. They are haploid cells, so they cannot be cultured, and knockout mice models tend to be self-limiting experiments. So what do we know? Well, sperm motility is correlated to male fertility, both natural conception and success at ART, and therefore represents an attractive therapeutic target. We also know that changes in intracellular calcium are fundamental to sperm motility and function, including fertilization at IVF. Intracellular pH is also crucial to sperm motility and fertility. And although there are calcium stores within the sperm, intracellular calcium and pH are primarily determined by ion channels and transporters in the sperm plasma membrane. The discovery of CatSper, cation channel of sperm, has massively advanced our knowledge and understanding of sperm function in the last decade. It is located in 4 nanodomains, arranged like racing stripes along the principal piece of the flagellum. Catspur is a sperm-specific ion channel and permeable to calcium. The Catspur ion channel complex is large. There are 4 subunits, 1, 2, 3 and 4, 6 auxiliary subunits and a chaperone protein, Catspur tau. All subunits are required to produce a functional channel. It is activated in response to a number of agents, including progesterone, prostaglandins, and an increase in intracellular pH. HV1 is a voltage-gated proton channel. Like Catspur, it is located in nanodomains along the flagellum, although these are located asymmetrically and responsible for sperm rotation. Importantly, we and others have demonstrated that a significant proportion, perhaps around 10%, of problems with fertilization arise from ion channel dysfunction, and that Catspur activation is vulnerable to a number of environmental, cosmetic, and dietary molecules which may mimic the action of physiological ligands and interfere with the precisely coordinated sequence of events underlying fertilization. High-throughput screening is one approach taken to drug discovery and represents a time and resource-efficient method of identifying potential compounds as new drugs. At the University of Dundee, we have a unique resource, the Drug Discovery Unit, a department with biotech and pharma capabilities, which carries a remit for drug discovery in neglected diseases and novel therapeutic targets. They have compiled libraries of small molecular compounds which are specifically designed for lead-like characteristics for medicinal purposes, some of which we have now screened for Catspur responses. The National Phenotypic Screening Centre is also located within the University of Dundee and offers state-of-the-art integrated robotics, screening platforms and automated workflow systems to efficiently screen small molecules for effects that alter the phenotype of a cell in a desired way, for example, sperm motility. And in the last few years, we have developed and validated robust high-throughput and phenotypic screening assays to drive forward drug discovery for male infertility and contraception, with an overall aim to develop a prescribable treatment. But we've still got a long way to go. In the meantime, IVF-ICSI represents pretty much the only treatment option for male infertility. But don't underestimate the implication of this for the couple sitting in front of you in clinic. Many men will feel upset and guilty that their partners are subjected to invasive treatment because of their own fertility issues. However, it may be useful to consider life exposures, such as smoking, alcohol, obesity and diet, because even if it doesn't make a fundamental difference to his fertility, it at least empowers men to take ownership of their personal health. Smoking is the leading preventable cause of early disease and death in the Western world. Estimates by the American Cancer Society suggest that it can shorten lifespan by up to 12 years in men, mainly due to pulmonary and cardiovascular complications. But smoking can also affect the reproductive system. A meta-analysis by Lee et al., published in 2011, included 57 studies and almost 30,000 participants, and showed smoking to have negative effects on all semen characteristics. A more recent publication by Bunden et al. In 2019 included 16 studies and almost 11,000 participants, and showed that smoking negatively affected sperm count and normal morphology, but with little effect on motility and no increase in probability of azoospermia. Intriguingly, another study by Wesselink et al. In 2018 included 5,473 female and 1,411 men who were planning pregnancy, and showed no clear association between smoking, male fertility and chance of conception, although only a small number of studies were included, and these were highly heterogeneous. Nonetheless, smoking does appear to negatively impact on ART outcomes. The slide here presents evidence for smoking cessation in preparation for ART, although again, study numbers are small. Obesity increases the relative risk of low sperm count. A BMI over 35 also significantly increases the chance of azoospermia. But what is very much less clear is whether weight loss can reverse male infertility. Certainly the effect of weight loss intervention is variable and may depend to some extent on the speed of weight loss and nutritional status. There are mixed reports of decline, static, as well as improved male fertility following bariatric surgery, which may relate to this point. It is also worth noting that weight loss intervention is very complex and not only requires a change in calorific intake, but also modification of diet, lifestyle, exercise, and so on. A recent comprehensive systematic review of observational studies has also demonstrated associations between diet and nutrient intake and male infertility. Diets rich in omega-3, antioxidants and vitamins, including vitamin D and folic acid, and low in saturated fats were positively associated with semen quality. This diagram demonstrates associations found between diet and abnormal semen analysis and/or male reproductive hormone levels, with green items showing a positive association and orange items showing a negative association with male infertility. Notably, high intake of caffeine and alcohol, a diet high in sugar with sweets and sugary beverages, and high consumption of red meat and processed meat were all negatively associated with a lower chance of pregnancy or fertilization rates in their partners. Reactive oxygen species include oxygen ions, free radicals, and peroxides. They're generated during normal cellular respiration but are high energy molecules and potentially destructive. Antioxidants are protective against reactive oxygen species, and those found naturally in semen include vitamin C, vitamin E, vitamin B9 or folic acid, as well as trace elements zinc and selenium, and micronutrients such as carnitines and carotenoids. Oxidative stress occurs when the production of reactive oxygen species exceeds natural antioxidant defences. Sperm are particularly susceptible to oxidative stress, and a significant body of evidence supports the role of oxidative stress in sperm dysfunction. Antioxidants would therefore perhaps represent a logical therapeutic approach to male infertility. The recent Cochrane review of antioxidants for male infertility included 61 studies evaluating 18 different antioxidants. 6,264 subfertile men were included from the age of 18 to 65 years old. However, most studies only reported an effect on semen analysis parameters as their primary outcome, with no attempt to capture pregnancy data or outcomes. Only 4 studies evaluated live birth rate, and only 7 evaluated clinical pregnancy rate. And whilst these supported a positive role for antioxidants, numbers are small and the evidence remains poor. There was insufficient evidence to demonstrate any difference or reduction in miscarriage rates, and the authors conclude that more high-quality, larger, placebo-controlled trials reporting on outcomes and adverse incidents are required to draw definite conclusions. 2 randomised controlled trials have been reported since the most recent Cochrane review. The FAS-ST study included 2,370 men, randomised either to high-dose folic acid and 30 milligrams of zinc for 6 months or placebo control. There was no change in any semen analysis characteristics, although a supplementation appeared to be associated with an increase in DNA fragmentation. There was no effect on clinical pregnancy or live birth rate, and no effect on miscarriage, although notably the incidence of preterm birth was significantly higher in the group allocated to antioxidant supplements. The Males, Antioxidants and Infertility or MOXIE trial was a multi-centre randomised controlled trial comparing the use of vitamin C, vitamin E and folic acid, selenium, zinc, lycopene and L-carnitine supplements to placebo control. Patients were treated for 3 to 6 months but no improvement on semen analysis or DNA damage was reported, and no increase in clinical pregnancy or live birth rate. So, vitamin and dietary antioxidant supplements are increasingly controversial, as efficacy of effect is indeterminate, and findings of increased risk of preterm delivery suggest that they may not be completely harmless either. Sleep disturbance is common, and its prevalence is increasing. The influence of sleep or sleep disturbance on a range of physiological processes is well recognised and may also contribute to male infertility. Testosterone secretion follows a diurnal pattern, with rise in testosterone levels coinciding with rapid eye movement or REM sleep, rather than with changes in levels of melatonin. Prolactin levels are also sleep dependent, with an increase in prolactin secretion during sleep. Sleep duration has been reported to be associated with testes size in healthy young men. Obstructive sleep apnea, characterised by repetitive nocturnal hypoxia, is associated with increased levels of oxidative stress, independent of obesity or reproductive hormone profile. Psychological stress has been reported to be linked to semen analysis abnormalities, with the highest levels of stress having the most significant effects on sperm count. An association has also been reported between stress and depression and semen quality for those experiencing fertility issues, and it is entirely possible that combined or interacting effects of stress, depression and poor sleep on semen characteristics may well be significant. As a result, non-pharmacological stress management, including fertility counselling and men's support groups, can be hugely beneficial and should therefore be promoted by clinics. The coronavirus pandemic has clearly been a very stressful time for patients, not least because of abrupt suspension of fertility services, unnecessarily cautious and slow resumption of treatment, compounding backlogs and waiting times. We devised a questionnaire specifically for men experiencing fertility issues, and I'd like to share some of these preliminary results. 96 questionnaires have been returned to date, either completed in clinic, by phone or online. We asked, how has the coronavirus pandemic affected your well-being? And asked men to assign a numeric score. Most reported no or moderate effects on their well-being, perhaps as expected. However, 4% reported being badly affected. Almost a third of men reported that the coronavirus pandemic had made infertility harder to cope with. 74% reported no difference to their sex life, despite lockdown, suspension, or delay in fertility services. We asked men how they felt about visiting hospital or a fertility clinic to undertake treatment. Whilst the majority reported feeling safe, almost 1/3 reported feeling anxious, and 2% were very worried or too worried to even attend clinic. 1 in 5 men reported worries about starting a family or becoming a dad again, citing concerns relating to themselves or their partner's well-being, uncertainties about the safety of pregnancy, or money or employment worries. We also asked, if you knew for sure that the pandemic would be open by next summer, would you postpone your fertility treatment until this time? The majority answered no. We asked, in the event of a second wave, do you think fertility services should be suspended again? Again, the majority answered no. We asked whether they had used counselling services because of the coronavirus pandemic, and again, almost all answered no. And yet, when we asked, have you had enough support from your fertility clinic? 1 in 7 answered no. Lastly, we asked for other comments and suggestions on how men could be supported more, and then made a word map based on the answers supplied. As you can see, focused men support and mental health was a common theme. Men also felt excluded and overlooked when prohibited from attending treatment monitoring appointments with their partner. This is a challenge we now hope to address and raises the need for men's support groups instead of, or as well as, fertility counselling. So here are my key messages to developing a holistic approach to male infertility. 1. Be honest with your patients. Let them understand the limitations of current science relating to sperm biology and function, and acknowledge the current lack of treatment options. Get involved in research if you can. 2. Empower men to consider changes to their life exposures. Fertility is a big motivator for kicking bad habits. And don't underestimate the importance for him to be able to take control of some element of fertility interventions. 3. Fertility supplements are increasingly controversial, expensive, and perhaps not without risk. 4. Include men in your conversations. Of course, talk to the couple about treatment, but don't forget the contribution of the sperm. Spermatogenesis takes around 10 weeks, so this can be a timeline for lifestyle focus in the run-up to treatment. And don't forget the importance of abstinence and producing a sample on the day. 5. Men's support groups and mental health are really important, but may not be addressed by traditional fertility counselling. What does your clinic offer, virtually or otherwise? And if you are lacking support for men, then signpost them towards online support groups, for example Man Cave or Him Fertility Male Support Group on Facebook. Thank you, and my references follow.
Thank you, Sarah, for that very informative and instructive talk. We'll now move on to our second speaker, Dr. Denny Sakkas. Denny received his undergraduate training at the University of Melbourne in Australia and his doctorate of philosophy at Monash University, also in Melbourne. Dr. Saccas has served as the scientific and laboratory director of IVF units in the USA, Switzerland, and the UK, and has aided numerous groups in establishing their own IVF units around the world. He has extensive experience in clinical and commercial IVF and reproductive research, and is internationally recognized, having published more than 200 manuscripts, books, and chapters in the field of fertilization, early embryo development, and male infertility. He is currently on the editorial board of 5 leading journals. He has a H-index of over 66 and over 15,000 citations. Dr. Saccas is currently the Chief Scientific Officer at Boston IVF and remains an Associate Professor at the Department of Obstetrics, Gynecology and Reproductive Sciences at the Yale University School of Medicine. So now it's over to you, Denny.
Welcome to this Cooper presentation. My name is Denny Sakkas and I'm Chief Scientific Officer for Boston IVF in Massachusetts, USA. And today I will be talking about developing a holistic approach to the subfertile man. My disclosures: I'm a member of the Scientific Advisory Board for iGenomics. I speak for EMD Serrano Journal Clubs. I'm a consultant to 2 male factor companies, Ohana and Legacy, and of course I'm a paid speaker for this Cooper presentation. My only other disclosure is that I produce sperm and that I'm going to be slightly biased towards the male. So part of today's topic will be about the man in the journey of the infertile couple. And sadly, the man is sometimes forgotten in this journey. And what I'm going to talk about is reproductive failure. So what happens when a couple fails in their attempt to reproduce? Well, we know that the queen of reproduction is the egg. And in most cases when a reproductive failure occurs, the egg is actually the main one responsible, and you could gauge that to about 70 to 80% of the responsibility of reproductive failure is towards the egg. But you can't forget the uterus, so you could gauge another 10 to 15% for the uterus, but you cannot forget the sperm. And in 10 to 15% of cases, you could probably blame the failure of reproduction or achieving a pregnancy completely to the sperm. And we also have to remember that the sperm is 50% of the genome. The worse the sperm, the more abnormal that sperm is, the greater that negative influence. So if you're looking at a poorer sperm, a male factor infertility patient, you can see that the influence on that embryo development and live birth and future generations could actually be a greater impact. Of course, the couple's journey has many, many steps, and these steps will lead to either a success or a failure. And what I'm going to talk about is how sperm impact that success or failure. Of course, in part of those steps, the sperm is involved, or the male is involved in sperm analysis, in sperm preparation, and, of course, in IVF and ICSI. The couple's journey, then, involves these three key factors within the man for sperm analysis, sperm preparation, and IVF and ICSI. So what is the current approach to treating the subfertile man? Of course, it's semen analysis. What we count, how many sperm there are, and are they moving? That's the basic premise of a semen analysis. And is it below or above WHO parameters? And of course, this will guide to whether you're going to do an IUI, an IVF, or an ICSI. There are other factors, though, that might impact on that choice, and that's depending on insurance coverage, on how that clinic practices, and of course, you will look at the sperm parameters. But it is interesting that about 2/3 of IVF cycles around the world use ICSI. And why that is probably more a matter of convenience, and also that many of those ICSI cases are actually not male factor infertility cases. And there is so much more to sperm than just looking at whether a sperm is moving or not. Of course, one of the things that is most important is how that genome is actually packaged, how the DNA is actually packaged. You can see this in this movie. You can see a DNA strand. This is actually a histone, and in sperm you have protamine, so the packaging is actually very different from what I'm showing here. But you can already see the intricate way the DNA is packaged to form the chromosome. If anything goes wrong in this process, it will have implications on the future fertility of that couple. So what other factors can impact reproduction, and what factors are associated with the man? So here are some papers by Kandwala and colleagues looking at the association of paternal age with perinatal outcomes. And what's interesting, when you control for maternal age, you can see that as male age advances, the relative risk of having an adverse perinatal outcome increases dramatically, indicating that the sperm from older men is actually somehow impacted and will actually affect reproductive outcome. When we examine the DNA of sperm, we see a persistent story that if the DNA is abnormal, then the chances of that partner having a miscarriage is actually quite high. And this is a really good study by Doug Carroll and colleagues that's been repeated by other groups now, looking at patients or couples that experience recurrent pregnancy loss. And what they found was that in couples that experience recurrent pregnancy loss, they found that the husbands or the male partner generally had much higher levels of DNA damage in their sperm. The story of how a sperm can affect outcome of a pregnancy doesn't just end with, say, miscarriages or a live birth. It actually has been shown in various animal models that there are transgenerational effects of an abnormal sperm for going from one generation to the next. And we're now starting to see this also in epidemiological studies in the human, where events such as smoking can affect not just the son, but the sons of sons. And we're also seeing these transgenerational responses in humans also in relation to environmental exposures. So the story of how an abnormality in sperm can be passed on is actually quite a complex one. And these transgenerational epigenetic programming is involved in the passage of certain environmental exposures or other stresses that go from one generation to the next. One of the most worrying factors is the relationship between age, or male age, or advanced male age, and neurodegenerative disorders. And this is just one paper indicating a relationship between male sperm mosaicism and autism risk in the offspring of these children. So, what can we do about this? How can we see the future of diagnosis and selection of good sperm? First, we have to understand what is a bad sperm. We can learn about bad sperm, or what is a bad sperm, from looking at older men. And this is a study done by Andy Weirbeck and Don Evanson many years ago now, showing that advancing age has different effects on DNA fragmentation and especially on mutation rates. So as men get older, their sperm quality declines quite dramatically. This is a study we published just last year looking at DNA fragmentation of sperm in a very high number of patients. And this also has been done by Don Evanson and colleagues recently. We looked over at nearly 17,000 patients and showed conclusively that as males age, their DNA fragmentation index, or the quality of that sperm, declines. So they have higher levels of DNA fragmentation. What is also interesting is that the oxidative stress adducts in those sperm also increase dramatically as men age. But what's interesting is that it's not just age that affects this, but you do have many younger men that actually show similar patterns of high DNA fragmentation and high oxidative stress adducts. If you look at these in relationship, you can see that normally, in most situations, where you have one, DNA fragmentation, you will also have oxidative stress adducts. But you do have independence in these parameters of sperm too. So the sperm population may only have DNA fragmentation, may also just have oxidative stress adducts, but it can also have DNA fragmentation and oxidative stress adducts combined. What has also been shown in a paper in Nature several years ago by Kong and colleagues is that the rate of de novo mutations also increases dramatically as men age, to the fact that there are probably about 2 new mutations each year as men get older. In association with that, Doug Carroll and colleagues have shown that age is also associated with alterations in DNA methylation, and that older men have higher levels of global methylation changes or abnormality or alterations in their methylation patterns. And importantly, a significant portion of these alterations occur at genes known to be associated with neurodegenerative disorders. And these in turn, as I said before, have been associated with certain disorders also in children from men. So what can we test for? We can obviously screen methylation patterns in mature sperm. And this has been looked at by Doug Carroll and colleagues, showing that the changes or alterations in DNA methylation do have a potential impact on the embryo and on offspring. What can they look at, and what have they found? They found that certain patterns in sperm methylation are actually highly related to embryos of poor quality. So there's a clear cluster of poor quality embryos in relation to specific DNA methylation patterns in a patient's sperm. We can also get other information from sperm, and hopefully in the future this is the way we will look at sperm. This is a paper that recently came out in Nature by Steve McCarroll's group here at Harvard University, and what they did was single cell analysis of actual donor sperm from from about 20 patients, but they could look individually at sperm and look at meiotic errors in that sperm. So this now forms a basis for what is a good sperm population that we can actually compare to actually infertility patients to see are there increases in meiotic errors in these types of patients. What is also interesting, you can use these methylation biomarkers, if you want, as an analysis for looking at responses to different drugs or different therapies. And this paper actually showed that by using methylation epimutation biomarkers, you could actually see if patients responded, for example, to FSH therapy. So, in the future, how will we do diagnosis and selection? Well, this is a great example of how to do diagnosis and selection in one shot, if you want. This is studies performed by Gabor Huzar's lab showing that using hyaluronan, which naturally occurs on cumulus cells, allows sperm to actually bind to the hyaluronan. You can see here bands of hyaluronan and sperm binding to them. And this tells you that these sperm are good because they have the receptor for hyaluronan. And also, those sperm that are bound, you could actually select those by using an ICSI pipette. So it tells you both that you could do diagnosis and selection in one shot. When these studies were conducted using hyaluronan to actually select the best sperm, you can see this HAB Select study performed by David Miller and colleagues and published in Lancet a few years ago. Unfortunately, it showed no difference in improvement in pregnancy rate, but what was interesting again is this story of miscarriage, that when you were able to select better sperm from this population, you actually significantly decreased the risk of miscarriage. So this actually goes again to show that there is a subtle change or subtle improvement in this type of sperm. One of the problems with this study, though, was that it actually looked at all patients coming in for treatment. And that included patients who were, such as patient A, who were very good. So patient A, you can see, has one bad sperm, but many, many good sperm. So probably is not that good a candidate, let's say, for sperm selection or sperm analysis. Whereas the patient B, you can see, has many abnormal sperm and only a few good sperm. So it's those good sperm you actually want to select. And this is the type of patient, patient B, that you would be looking at doing an analysis and sperm selection on. How are we going to do this in the future? I think the future of sperm selection is most likely going to be using microfluidics. Microfluidics really lends itself to sperm selection because it actually allows sperm to pass through certain mazes, if you want, of types of obstacles that will allow the best sperm to actually pass, similar to what happens in nature. So we've already seen microfluidic sorting experiments, and what we've seen is mostly that sperm are actually improved in their quality. They might not be improved in number and concentration, but actually the type of sperm you can collect is much better compared to how we do sperm preparations at the moment. For example, in this paper by Quinn et al. Published in Human Reproduction, you can see in unprocessed sperm, DNA fragmentation index is quite high, around 20%. In density gradient sperm, it's around 7-8%, but you can see the green column here in microfluidic sperm preparation, it approaches virtually zero. So you're virtually eliminating abnormal DNA sperm. Of course, there are other methods, and this is a method developed by John Aitken and colleagues. It includes some microfluidics, but it's more based on an electrophoretic sperm separation technique where it actually separates sperm based on their charge. So this has also been used and actually been used successfully in creating pregnancies. I think now there are numerous studies, clinical trials on microfluidics and on techniques such as the electrophoretic sperm isolation technique that will hopefully let us know if these types of techniques are able to actually distinguish good sperm and select sperm that will improve in IVF rates. The question remains, though, why don't we have a good sperm selection technology yet? Well, it's a bit more complicated to pick a good sperm. obviously, if you've got a sperm that actually has a chromosomal abnormality or a major defect in chromatin packaging, that sperm will impart its problem much earlier in the cascade of reproduction, if you want. The finer the problem, the more subtle the problem, it will take time to affect an outcome. So the smaller the problem, the longer it will take to manifest itself. And these problems, the small problems, the single mutation, will be seen maybe in miscarriages, as we're seeing in some of the data already generated. But maybe we will only see these in future generations, these problems. So our aim in the analysis is not looking at the big problems, is actually trying to diagnose the more subtle problems. So how can we develop a holistic approach to the subfertile man? What will be the future of semen analysis and ICSI? I think in the future we'll be able to test more males, and there'll be remote testing type of strategies that will allow men to actually produce samples at home and actually have those samples sent to genetics labs, to IVF labs, or specialty sperm analysis labs that will be able to conveniently appropriate these types of technologies and test sperm at a much higher level. But the more sperm populations we can test, the more information we'll get. What other techniques might be available in the future? And some of this work has been done by Charlie Borman and colleagues and Hardy Sheffy, looking at automation using smartphone-based diagnosis. So here you can actually do an analysis of sperm, and these types of analysis will allow you to do point-of-care semen analysis. So this is actually very exciting in terms of getting more and more data on sperm analysis. How will all these be integrated in the future? So how can we do analysis, sorting, and selection? And again, I think that you could create microfluidic chips that actually can do the analysis and actually allow more subtle analysis. And you could do these with home sperm analysis. You could actually do methylation analysis. And all these could be based on some sort of chip technologies. Obviously, sperm microfluidics would lead itself very good to actually sorting sperm, either by size or actually by adding in chemoattractants or antibodies in a type of microfluidic device that will allow better sorting of good sperm, similar to the hyaluronan concept. And obviously, microfluidics and optics lend themselves together, so you could envisage that once sperm are sorted, you could actually select those sperm even further by using some sort of optics such as Raman spectroscopy. These types of chips have already been tested, for example, and this is some studies by Segerink and colleagues in the bovine, but also in human, where they're able to actually sort sperm in a microfluidic chip and entrap those that actually have the correct morphology or correct size and actually allow them to be selected much more easily for something like ICSI. So these types of techniques are already starting to be adapted and are waiting to be tested clinically. So, what is the take-home message? Of course, we've got great techniques for choosing the best egg, maybe the best embryo, and also for looking at the uterus. But in the future, what we want to do is have a personalised ART for also picking the best sperm. So IVF in the future will also involve on making sure that you actually have the right paternal component when you're performing IVF to ensure that the reproductive success is actually optimized. So I thank you, and thank you for listening. And if you have any questions, you can contact me on either of these two emails. Thank you.
Thank you, Denny, and thank you again, Sarah. Thank you both for those excellent and insightful lectures. We can now open up the Q&A session, and I'll dive straight in and ask about high levels of DNA fragmentation. First of all, what are your opinions on making an assessment of DNA fragmentation a mandatory part of the semen analysis?
Well, I can speak from the sort of the research side, if you want. Maybe Sarah can talk about the sort of clinical side. But, you know, it's obviously a very controversial assessment. So I think it gives you information on the male side. What's happening in general in clinics is that it's sort of not the go-to technique. What happens, even in our clinic, is that it's a technique that doctors or clinicians or IVF clinics start looking at after maybe one or two failures of a cycle. So it's probably, I don't see it as a frontline technique to perform on couples, but I definitely see it as something that can give you more information once a couple has undergone a failure in an IVF cycle or even two failures.
Sarah?
Yeah, I mean, I would agree absolutely with Denny. I really genuinely don't see it as having a place as part of a routine assessment. On the other hand, I think the other controversies that sit within DNA damage and DNA fragmentation testing is what test do you use, how robust are your results, and what actually are you then going to do with an apparently abnormal result. And we then sort of revert back to this: do you treat them with antioxidants? Do we know that that's definitely the right approach? Should we be thinking about testicular sperm retrieval or some other means of trying to avoid oxidative stress? And actually, one of the other kind of slightly fundamental issues that I have with testing a raw, unprepared DNA sample for sperm sample for DNA fragmentation is exactly the reasons that we perhaps will move to microfluidics, that we prepare sperm by a density gradient or a swim up, is that we're trying to purify that sample to try and get rid of DNA damage, but actually sometimes inadvertently we create our own DNA damage during that process. So testing a sample without doing it in real time and without then the prospect to be able to select DNA intact cells doesn't really seem to me to be the right approach right now.
Can I ask then, Sarah, if we're talking about potentially using sperm preparation and sperm selection as part of our ART processes to reduce the impact of DNA damage, is there any role in those couples wishing to continue to try to conceive naturally? Is there any advice that would be given that's different on the back of a DNA damage assessment?
I mean, if I'm absolutely honest, I don't really use DNA damage testing at all in my own clinical practice. So I think it's very difficult for me to be able to kind of comment beyond what I would do in my own situation with a couple in front of me. I think, I presented some of the data about the Cochrane review of antioxidants for men and looking at the sort of pros and the cons within that data set and also the subsequent trials that have come out of that. There's also background with looking at, long-term selenium and other vitamin strategies in terms of exacerbating prostatic cancer or making lung cancer prognosis poorer. And so I think, we've always got this assumption that antioxidants or vitamin preparations, and the more, the merrier, is good and fine and safe. And actually, I think what we perhaps have learned from the FAS-SD trial was actually, there may be more to this than giving high-dose antioxidants may have a negative effect on pregnancy and outcomes as well. So if I've got a couple in front of me, they've got latent male factor infertility. Unless he's azoospermic, I'm never going to say to a couple, you're not going to ever get pregnant, because we've all got stories of people that did. But on the other hand, I think it's not very kind and it's not very realistic to say to a couple, keep trying when his sperm count or motility is very, very poor. And that's why we have IVF and the luxury of ICSI to add to IVF, which is obviously the treatment of choice for male factor. I guess, what I really want to see is different treatments coming online, something that you can directly give to the man to boost his sperm count or improve his sperm motility. But we're not there yet, as I said in my talk.
And Denny, those samples that you identify with high levels of DNA fragmentation, what do you do differently in the laboratory?
So, our go-to technique, and basically for me it's a historic technique that I prefer because I worked so many years with Gabor Huza, is the hyaluronan system, or I think commercially known as the pixie dishes. So I always thought it was a brilliant, simple idea that, you have a technique there that allows you to pick a sperm. The concept of the hyaluronan is that, the sperms come through the production line containing the correct receptor, so it's been manufactured properly, if you want, and it binds to hyaluronin, which is like a naturally occurring substance, and that if you can pick that sperm, then it's more likely to be a sperm that is normal, let's say. And with Gabor's lab, we did many studies correlating, hyaluronin binding to DNA fragmentation, apoptotic markers, various, even chromosomal numbers. So I think that technique's interesting. So it's something that marries diagnosis or analysis and diagnosis, and I think that's where I think we should probably go. And that's where, that's a technique that sort of, at least in our hands, is something that we go to.
Great, thank you. Just moving on and changing tack a little bit, we've had a really interesting question asking whether the holistic approach to the subfertile man would be more effective if there was some system of regular, maybe annual screening so that problems were detected earlier and then appropriate advice given at an earlier stage, so planning is better perhaps. Do you have a view on that perhaps, Sarah?
So I meant to look this up actually because I think there is a specific definition for what a screening test needs to be. And I think part of that is being able to detect the problem, having an effective earlier intervention to prevent medical deterioration or whatever. So the cancer cervical screening program is a great example of that. The issue is that there's so much about male infertility that we genuinely don't understand. And therefore, if you don't, as I say, understand what causes it, then how on earth can you then, what do you do? What intervention do you do? Are you going to suggest that everybody banks sperm when they're 21? And then, we all know that sperm doesn't freeze and thaw well all the time. So therefore, you're going to have half the population that are committed to ICSI, where they might have come to that later in the day anyway. So I genuinely think we need to know more about men. And I think that sounds very trite, but it doesn't mean to come across that way. But I love the idea, Denny, of your remote semen analysis testing. And the thing that struck me is I've got a bracelet on my wrist that's monitoring my pulse and all the rest of it, just because I'm curious about how I sleep and what my heart rate does during the day, for fitness's purposes. But there's plenty of other people that wear these type of technological devices. And is there any way that you could marry up that with your oxygen saturations or, your testicular temperature or your environmental, whatever you're exposed to, toxins, with then remote immediate testing of your semen analysis there could be incredible biological banks that you could come across in that way, which don't involve a screening program, but involve people being really engaged with learning more about male reproductive potential, male reproductive health.
And I think that's exactly sort of the point I was trying to get across, that in effect, the males we mostly look at it have, either as a couple they have an issue or they have an issue themselves. So I think if you can get more information, a greater data bank if you want, and also, if you can do, I think someone asked an interesting question, do you do a yearly test? That if you can actually get a timeline for each individual male, then, maybe we will understand much more about how you can relate male infertility to health, and there are studies looking at that now. So I think we'll get a much better understanding. I think we really, we haven't really delved enough into this story about male infertility yet, because, as I said, most of the infertility couples we looked at, sadly, when the couple comes in, the doctors look straight at the female and forget a lot to talk to the male or to look at them.
And we had a question asking, sort of leading on from that, whether the role of the andrologist has been minimised. Are we guilty, perhaps, in recent past of overlooking a deeper assessment of the male partner and his gametes?
So, I think, sorry, Sarah, I can answer that. I think ICSI is such a remarkable tool that sadly it's overtaken that, that role in effect. And just look at, like I think I mentioned in my talk, that 2/3 of IVF cycles are done by ICSI now. There are many countries where it's 100%. So sadly, that means it's, people aren't really looking at what, what the male has. I know many clinics where the IVF doctors don't even examine the male. It's not even thought of. So, I think the short answer is, it basically is the forgotten man. I'll let Sarah answer it more clinically, though.
Well, no, I jump straight in there and say exactly that. And I think we as gynaecologists, because we are women's health specialists that deliver the kind of medical care of IVF, we've really missed a trick here. I think about a woman that comes to clinic, I'll take a history from her, we do bloods to assess her hormones, ovulation, an internal scan, and yet the man is parked next to her and we don't take that same, kind of interest and investigation and query into him, and that's wrong. Actually, that's wrong. And I think every man and every woman in front of you should be examined. I think we'd be much more focused. We've got a questionnaire, probably won't surprise you, but we've got a questionnaire that the men fill in about what work do you do, are you doing long distance driving, are you sitting on a heated seat, how many hours do you use your whatever, what time do you go to bed. I just think I might not be able to fix or change any of those things, and he might not be able to fix or change any of those things, but at least to try and get a critical mass of information. But why we don't examine the men and why we don't give them even just simple advice about ejaculatory frequency, preparation for IVF ICSI, all of these things are just water slipping through our fingers, where we could be actually dealing much more with the couple as a couple rather than the couple as we're doing this treatment to this woman and she's having IVF and we just need a sperm sample from you at some point.
I'm going to squeeze in one quick question if I can. Time I know is getting short. But leading on from that, Sarah, do you think that for instance, in the COVID pandemic, with the rise of sedentary lifestyles and now people working from home and not going very many places, is all that impacting the male fertility, and what advice do you give?
So great question, and I think it's something that we genuinely won't know the answer to. I have a fantastic job in the sense that half of my time is clinical and half of my time is teaching and research, and I have days where I can literally go from Zoom to Teams to whatever, from meeting to meeting without going anywhere. On the other hand, I do love the opportunity to be working from home, to set my own timetable. I will often go for a long dog walk in the middle of the day rather than sat in front of a computer having a sandwich if I'm in the hospital. So I think there is the potential for us to be healthier, to be outside more, and to utilise that lost time of commuting in a beneficial way. On the other hand, I think the temptation, particularly at this time of year in the UK, certainly, is to stay cosy and warm and not bother going anywhere, and perhaps not even bother getting out of your pajamas. So I think the difficulty is how that will play out. If we'd been really clever, it would be useful to have seen a group of men and followed them through time. Like Denny was saying, maybe not even annually, but 3 monthly, and see, with these great changes and shifts in lifestyle, what do you see in a population of men? Do you find it less stressful, and you might see sort of subtle improvements, or do you see a problem there? And I think the jury's out. We don't rightly know just yet.
That's great. Anything to add, Denny?
No, it is interesting to see what will happen, post-COVID. I think as Sarah mentioned, it's a plus and minuses. You're at home, you're sitting all day on the Zoom calls, and I know a lot of people, putting on weight basically. So, and we know about obesity and that. So it is interesting the change in lifestyle, how it will impact males, and also we've seen with females too. The same. So that I think it's an experiment in motion, let's say.
Absolutely.
I have to say, one of the most interesting things on the COVID questionnaire that we did is we genuinely thought if people are all stuck at home, no prospect of having fertility treatment, they would have miles more sex, and probably more of them would get pregnant, and that actually wasn't what we saw. So it's quite interesting to see that kind of impact, we kind of anticipated that perhaps we'd have this baby boom because everyone had been at home, and even infertility patients would be having far more intercourse, but that doesn't appear to be the case. So